Eisenmenger syndrome or complex. Eisenmenger syndrome is a term that applied to any large communication between the systemic and pulmonary circulation that results in irreversible changes in pulmonary vascular bed with reversal of the shunt direction. Eisenmenger disease is used to describe the combination of VSD, severe pulmonary hypertension, and consequent right to left shunt. It is also called Eisenmenger complex. Now, precipitating congenital heart disease that causes Eisenmenger syndrome. Most common causes are VSD, ASD, PDA, and less common causes are atrioventricular septal defect, truncus arteriosus, aortopulmonary window, detransposition of great vessels, surgically created aortopulmonary connection, example BT shunt, single ventricle. Now, pathophysiology. Left to right shunt, increased pulmonary blood flow, endothelial dysfunction and vascular remodeling, that is thickening of intima, hypertrophy of media of pulmonary arterioles, causes increased pulmonary vascular resistance, causes reverse shunt, that is right to left shunt, and features of Eisenmenger syndrome. Now, what are the clinical manifestations of Eisenmenger syndrome? The symptoms are related to low cardiac output, that is dyspnea, fatigue, syncope on exertion. Right to left shunt causes cyanosis, palpitation. Central nervous system abnormalities includes headache, dizziness, stroke or cerebral embolism. Dyspnea, angina, syncope on exertion, hemoptysis. Features of heart failure. Coagulation abnormality includes bleeding, thrombosis, hemoptysis, pulmonary infarction. Others are chest pain, joint pain. On physical examination, cyanosis, clubbing, JPP raised, pulse, small volume. Features of pulmonary hypertension, palpable and loud P2, left parasternal heave and murmur. Features of right heart failure, that is edema, ascites, and large Stendhal liver. Features of underlying cause, and there is pulmonary regurgitation murmur, that is Graham Still murmur. What is the complications of Eisenmenger syndrome? They are hyperviscosity, cerebrovascular disease, renal dysfunction, hemoptysis, hyperuricemia and gout, hypertrophic osteoarthropathy, cholelithiasis, hemostatic abnormalities. Now, cyanotic congenital heart disease in the adult, Eisenmenger syndrome. In adults, inoperable cyanotic congenital heart disease is usually a result of the Eisenmenger situation with pulmonary artery pressure at systemic level and bidirectional shunting through an ASD, VSD or PDA. It may also be caused by incompletely corrected phalanstetralogy or more rarely Epstein anomaly, pulmonary atresia or truncus. High blood flow in the first year of life results in a reactive medial hypertrophy of the pulmonary arterioles. There is additional intimal hyperplasia and narrowing of the arteriolar lumen results. Pulmonary artery pressure rises and the shunt becomes bidirectional. The PVR rises to more than 800 dynes as per centimeter to the power 5. Normally, it is less than 200. There is thus a combination of vasoconstriction and vascular remodeling. The rate of progression seems to depend on the shunt side. In infancy and childhood, 80% of patients with Eisenmenger syndrome have a VSD, and in adults, most have an ASD. This diagnosis may be missed in childhood. The PVR is fixed if it does not fall on breathing 100% oxygen. Patients with a fixed PVR seem to survive better than those with primary pulmonary hypertension. Median survival is into the 1330s. The heart in these patients is very preload dependent. A drop in venous pressure, that is hemorrhage dehydration, is poorly tolerated. Ventricular function is usually maintained. Bosentan, a dual endothelin antagonist, may improve exercise capacity in these patients. Endothelin levels are known to be raised in Eisenmenger syndrome. In a few young patients, heart-lung transplantation has offered the only hope of a cure for Eisenmenger syndrome. Early results are good, and at least one woman has had a child after heart-lung transplantation. Careful follow-up of these patients is essential because there is also a great number of non-cardiac problems that must be considered. Polycythemia. This is caused by erythropoietin production secondary to chronic hypoxemia. Oxygen delivery is increased with the rise in hemoglobin. Although theoretically physiological, it is counterproductive because it results in hyperviscosity and hypervolemia. This causes headaches, blurred vision, and a muddy head with reduced cognition. Patients appear plethoric with suffused conjunctiva. Retinal veins are engorged and tortuous. Scotoma leading to total blindness in one eye may develop with retinal vein thrombosis. Pruritus may be a nuisance, particularly after getting out of a hot bath. More serious complications include venous and less often arterial thrombosis, gout, and peptic ulceration. Venesection is necessary if the patient develops these symptoms or if the hematocrit or packed cell volume exceeds 65%. Earlier enthusiasm for venesection at lower PVCs resulted in iron deficient cells. These are more spherical, less deformable than normal cells, and may themselves result in sludging. Aim to keep the PCB between 55 to 60 seconds. True drip lines are required for simultaneous venesection and the administration of the same volume of a plasma expander or colloid. It is important to avoid any fall in circulating volume. A strict aseptic technique is required because these patients often have acne and are vulnerable to infection. Generally, it is sensible just to remove 1 unit of blood, that is 450 to 500 ml, over 1 to 2 hours, and to measure the PBC the following day once equilibrium has occurred. After venesection, the patient should feel improved with a clearer head, better exercise tolerance, less dyspnea, and better appetite. It is better to decide on a venesection on the basis of the PCB rather than the hemoglobin level. Iron deficiency may develop with repeated venesection and should be treated with low dose oral iron, that is ferrous sulfate 200 mg once daily. Bigger doses will result in the patient requiring more frequent venesection. There is a fine balance between excessive venesection causing dyspnea from anemia and inadequate venesection causing it from hyperviscosity. Now, bleeding disorders. Paradoxically, in a condition where thrombosis is common, bleeding abnormalities also occur. Platelet function may be abnormal and clotting factors may be deficient. There may be occult gastrointestinal bleeding from peptic ulceration, and aspirin and non-steroidal anti-inflammatory agents should be avoided. Patients may have troublesome epistaxis or hemoptysis. The latter may be result of rupture of aortopulmonary collaterals or larger pulmonary arteries. These may be catastrophic and fatal. Fresh frozen plasma and or platelet transfusions may be needed, especially pre and post cardiac catheterization or surgery. Cardiac catheterization should be avoided in the severely polycythemic patient and delayed until after venesection, with the risk of contrast media inducing a deterioration in renal function and the risk of venous thrombosis. Dental hygiene. Frequent visits to the dentist are often necessary because adults may contract periodontal disease and gingivitis. A dental brace is a particular hazard for this group, with the risk of infected gums seeding the circulation and causing a cerebral abscess. Skin. Acne is a common problem and septic foci must be treated early. Long-term tetracycline therapy may be indicated. Cerebral abscess. This is a recognized hazard of dental or skin sepsis, the passage of bacteria across a septal defect being the result of the bidirectional shunt. The development of neurological symptoms or signs, drowsiness, or a pyrexia of unknown origin requires urgent investigation, a cerebral CT scan, and neurological expert. Gout and bone pain, a common complaint that can usually be managed with long-term allopurinol 100 to 300 mg once daily. Renal function must be checked in these patients. Hypertrophic pulmonary osteoarthropathy may cause bone pain, with the periosteum reacting to an increase in growth factors. Now, pregnancy and contraception. This is contraindicated because it carries a very high maternal mortality rate, that is more than 60% with Eisenmenger VSDs. Spontaneous abortion is very common. It is very important to give early and clear contraceptive advice to all women with cyanotic congenital heart disease. The pill is best avoided. Thrombosis risk. The intrauterine contraceptive device is also best avoided. Bleeding and endocarditis risk. The best advice is sterilization by tubal ligation, which is probably achieved most safely by a mini laparotomy rather than a laparoscopic technique. It is very unlikely event of a woman refusing all this advice and coming to term the outlook is grim. Caesarean section should be considered electively at 36 to 38 weeks with great care paid to volume replacement and oxygenation. Epidural anesthesia has been recommended rather than a general anesthetic, but the systemic vascular resistance must not fall. High altitudes, heights of more than 1000 meters should be avoided unless inhaled oxygen is available. Patients should receive inhaled oxygen throughout commercial flights and should avoid flights in light aircraft without oxygen. Vigorous exercise, this should be avoided. Right to left shunting may increase as systemic vascular resistance falls with a muscle bed dilatation. Arrhythmias and sudden death have been provoked by effort. Antibiotic prophylaxis. This is routinely given before any dental or surgical procedure. General anesthesia. This is not contraindicated but may be hazardous. Dehydration and hypotension must be avoided with the risk of increasing the right to left shunt. Ketamine 1 to 2 mg per kg is a good drug for induction, having little effect on systemic or pulmonary vascular resistance. Volume replacement and small doses of phenylephrine 2 microgram per kg may be needed to keep up the arterial pressure. Post-operative heparinization will prevent venous thrombosis. Now, heart-lung transplantation. With a very limited donor supply, it is sensible to refer patients who may be suitable for this early rather than to wait for a crisis. Patients generally should be less than 50 years old. Results are not as good as for heart transplantation alone. The main indication for this is a rapid deterioration in symptoms. Example: end-stage pulmonary vascular disease, frequent hemoptysis, syncope at rest, refractory arrhythmias, severe hypoxemia causing angina, refractory right heart failure. Single lung transplantation with correction of the intracardiac defect may be a possibility in the younger patient who is deteriorating. The results of this operation are not yet quite as good as combined heart lung transplantation. Problems with the single lung transplant include post-operative early pulmonary edema in the transplanted lung, breakdown of the bronchial anastomosis, and late obliterative bronchiolitis. Relative contraindications to transplantation include malignant disease, moderate or severe renal or hepatic dysfunction, that is creatinine clearance less than 50 ml per minute, severe chest deformity, previous lung resection or pleurectomy, positive serology, HIV, hepatitis B or C. Pulmonary aspergillosis, active infection on high-dose steroids, multisystem disease, diabetes, collagen vascular disease, active peptic ulceration, peripheral vascular disease, psychiatric condition, drug or alcohol abuser. The final decision is team-based and also involves assessment of the patient's social circumstances, family support, etc. Both the patient and his or her family need to know both the risk of the operation and the subsequent management, which places considerable demands on them. Now, what are the tests to test and diagnosis for Eisenmenger syndrome? ECG. ECG shows right atrial hypertrophy, P pulmonary, right ventricular hypertrophy. Chest radiograph shows oligemic lung fields, pruning of pulmonary vessels. Echo shows pulmonary artery systolic pressure raised. Cardiac catheterization, blood test for CVC, renal and liver function, iron, ferritin, uric acid level. Platelet function, clotting factor deficient. Now, what is the management? General measures includes avoid strenuous exercise, avoid high altitude, that is more than 1000 meter, avoidance and management of volume depletion, avoid pregnancy, avoid situation that can exclusively lower BP like hot bath, avoid lifting heavy weight, avoid smoking. Be cautious with any medication and supplementation. Oxygen therapy if needed. Venesection in severe hyperviscosity. Dental hygiene, frequent visit to dentist. Acne, long-term tetracycline therapy. Now, what are the medications we can use? 1. Diuretics, digoxin, aspirin and other anticoagulants. Diuretics, digoxin, aspirin and other anticoagulants. Management of complications, that is polycythemia, bleeding disorder, cerebral abscess, gout and bony pain. Targeted therapy. What are the targeted therapy? Endothelin receptor antagonist, example bosentan. Phosphodiesterase type 5 inhibitor, sildenafil, tadalafil. Prostacyclin and prostacyclin analogs, IV epoprostenol, long-term IV. Surgery, lung transplantation and repair of cardiac defect, heart-lung transplantation. Thank you.